Hello, good morning to all. I'll be presenting SD OCT based imaging biomarkers for visual prognosis in eyes with macular edema secondary to retinal vein occlusion. So coming to the introduction part, briefly I'll be describing retinal vein occlusion is a common vascular disorder of retina and one of the most common cause of vision loss worldwide. It is the second most common cause of blindness from retinal vascular diseases after diabetic retinopathy. So occlusion can be divided into central retinal vein occlusion or hemiretinal vein occlusion depending upon the site of occlusion. It is significant that anti-VEGF strategies involving intravitreal injections have become a part of mainstream therapies for macular edema secondary to retinal vein occlusion. There is marked decrease in macular thickness after the therapy, but there may be chances that there are no improvement in the best corrected visual acuity, which suggests that macular thickness is only one factor out of several factors which affect the BCVA. So reason for limited visual acuity may include macular ischemia, photoreceptor dysfunction, accumulated subfoveal hard exudates, and disruption of inner retinal layers. So SD OCT now comes into a main factor which is a high-speed, high-resolution cross-sectional 2D image and is a powerful tool for the non-invasive assessment of retinal physiology. It also appreciates the individual layers and thus helps in the quantitatively analysis of all the layers. Despite the clinical relevance, these findings clinicians frequently have observed that eyes with poor visual outcomes, regardless of the complete resolution of macular edema, there are certain other factors which contribute to it. So for this, we studied the SD OCT based parameters, which included the integrity of inner retinal layers, including the inner nuclear and plexiform layer, ellipsoid zone disruption, and external limiting membrane disruption as the factors which can contribute for the decrease in not improvement of BCVA even after giving the anti-VEGF injection. So material and method included we included the treatment naive eyes with macular edema secondary to retinal vein occlusion. This was a hospital-based prospective observational consecutive case study. The sample size was 64. There were certain inclusion and exclusion criteria. Briefly describing about the inclusion criteria, we included treatment naive RVOs who had not gone for any other treatment before and were ready to give consent and the age above 30 years. Whereas the exclusion criteria were significant media opacity, history of cataract surgeries, any other confounding retinal diseases, history of any other previous surgery or pregnancy or any intravitreal injections. Approach to the patient was history was taken in detail, systemic examination was done, ocular examination with visual acuity examination, SD OCT was done on baseline after 1 month of injection and after 4 months of injections. There were 3 consecutively anti-VEGF injections which were given. Imaging modality which included was for each eye the scan passing through the foveal center was selected along with the 3B scan immediately above and below the fovea for a total of 7 scans with a 170 micron apart and a vertical height including of 0.72 mm. The SD OCT parameters which were studied were disorganization of retinal layers, disruption of ellipsoid zone, disruption of external limiting membrane, central macular thickness, and hyperreflective foci. Coming to the discussion part, in our study, 53% had BRVO, including ST and IT BRVO. And in bivariate analysis, we could find out that the changes in the following parameters, the drill and drill size was found to be significant after the anti-VEGF injection. In multivariate analysis, the whole cohort for each study group only change in drill size is significantly associated with change in visual acuity from baseline to 4 months post anti-VEGF. By using general linear regression formula, we found that an increase in drill size of around 90 micron is associated with reduction in 0.1 logmar in visual acuity. We did even a predictive model study which could predict that there is a significant association between predictive visual acuity and actual visual acuity. This was the chart which depicts all the parameters. And concluding for this, that there is a great extent of drill which is responsible for reduced visual acuity. This finding is explainable as disorganization represents a loss of bipolar amacrine or horizontal cells within inner retinal layers, which are important cells for transmission of visual data from photoreceptors to retinal ganglion. Further, in the predictivity model, we found that an increase in drill size of around 65 micron can predict a 0.1 logmar visual acuity at the end of 4 months. We also studied secondary outcomes like age, diabetes mellitus, hypertension, duration of hypertension, and type of hyperlipidemia, which did not come to be significant. Thank you.
Just a practical note, among all the biomarkers, which one do you think is the most significant for an ophthalmologist to see whenever monitoring any macular edema?
Sir, the most important biomarker which we see is the ISOS junction disruption basically. But if that is there, that means the visual acuity or prognosis of the disease after even injection is little poorer towards side. But in my study, the drill and drill size come to be associated with it. If there is increase in drill size, there was decrease in the logMAR visual acuity after the injection.
Thank you.
Thank you.
Thank you.